हेलो रमन।
गुड इवनिंग. गुड इवनिंग सर.
कैसे हो?
बढ़िया सर. बढ़िया. वी मिस्ड यू सर यस्टरडे.
वीक में पॉसिबल नहीं, बीच में निकलना ना थोड़ा सा। देखो
डिस्टेंस
खोपड़ियों के
काफी
लिए।
है. आपका डिस्टेंस
और कल
काफी.
मेरा एक कैंप ड्यूटी लगाई हुई थी।
अच्छा
तो
अच्छा.
उस चक्कर में मैं थोड़ा सा बाहर था।
ओके ओके ओके.
एक्चुअली इन्होंने बीजेपी वालों ने पता नहीं क्या सिस्टम चलाया, कैंप लगाने शुरू कर दिए साले।
अच्छा.
हाँ।
ओके.
मतलब कोई मतलब बनता है कि तुम टर्सरी केयर सेंटर छोड़ के और प्राइमरी केयर सेंटर में जाके बैठोगे?
गुड इवनिंग सर. रवि सर. सर अनम्यूट योर सर.
टेक्नोलॉजिकली चैलेंज्ड.
गुड इवनिंग सर.
हाय, कैसा है?
बढ़िया सर. सर डॉक्टर सुरेंद्र सिंघल सर. Sir is president of
हेलो
Haryana AOI and sir
हेलो
is
हेलो, हाउ आर यू?
professor at GMC Chandigarh.
थैंक यू फॉर दिस अपॉर्चुनिटी सर.
इट्स अ प्लेजर।
Good evening ma'am. Harsh. Hello Harsh.
Sir, hello.
ठीक.
Good evening, sir.
Good evening.
Good evening, ma'am.
Ravi sir.
हाय.
Hello, sir.
अच्छा, रवि सर.
Ravi Meher sir. Ravi Meher sir.
जी कनेक्टेड?
हाँ सर ने अभी म्यूट करा हुआ वीडियो.
यस।
Good evening, sir.
गुड इवनिंग डॉक्टर अवनी, हाउ आर यू?
Good, sir. How are you?
आई एम फाइन फाइन, थैंक यू।
हेलो मैम.
There is some network issue.
Hi. How are you?
देयर इज सम नेटवर्क इशू।
आपकी दुआ है मैम.
Avni ma'am, there is some network issue at your end.
हेलो.
So good evening sir.
गुड इवनिंग सर.
हाँ जी, गुड इवनिंग.
Good
सॉरी
evening,
आई एम
sir.
लेट.
नहीं sir, you're on time.
Actually, today, I mean, it was so much of traffic. I mean, it just reached
अच्छा.
almost 10 minutes.
Okay, okay.
Sir, good evening, sir.
गुड इवनिंग, हाउ आर यू?
Good
I'm
evening,
fine.
sir.
Hi, Avni. Hi, Ravi. How are you?
गुड सर.
So,
So we can sir start.
yes,
The
we
participant will keep on joining.
right.
Right. So good evening everyone. I'm Dr. Raman Sharma, assistant professor at Maulana Azad Medical College. So I invite everyone these academic lecture series that we are conducting under the aegis of Haryana AOI. So today we have a very unusual case presentation that is not usually discussed in the online platform in the PG teaching program. So we usually get carcinoma, buccal mucosa, gingival sulcus, tongue, but there are chances that you can get the oropharyngeal carcinoma as well in your exams. So this is the reason we are discussing an oropharyngeal malignancy in today's platform. So we have Dr. Harsh Bansal. He's a third year PG resident from ESI Faridabad. He will be presenting the case, and it will be like a mock exam. So we have 3 examiners. So our first internal examiner will be Dr. Avni Jain. Ma'am was earlier associate professor at ESI Faridabad. Now ma'am has joined as specialist in Safdarjung Hospital, Delhi. Second, we have our external examiners, Dr. Ravi Meher sir. Sir is a director professor at Maulana Azad Medical College. So every one of us know him. So thank you, sir, for coming. And third, last but not the least, we have Dr. Ravi Shankar sir. Sir is the consultant head and neck surgery at HCG Cancer Center in Mumbai. So sir was alumni of, he's a senior only from NAMC. He did his MS from Maulana Azad Medical College and he did his MCH in head and neck oncology from Tata Memorial Center. So thank you, sir, for sparing your time for this teaching activity.
थैंक यू रमन. थैंक यू सो मच.
So Harsh, you can take the permission of examiner and then we can start the case presentation. So
Hello.
Dr. JC Pass is also there. Good evening, sir.
Good evening, sir.
Very good evening.
Hello, Avni. How are you?
Good evening,
Good,
sir.
sir. How are you?
Good evening, Dr. Pasi sir, Dr. Surinder
Good
sir.
evening, sir.
Good evening, good
Hello,
evening.
how are you? How are you?
Fine.
So,
Nice to see old faces. Ravi Shankar. Ravi Shankar, where is Ravi Shankar? Bhupinder.
Good evening, Dr. Ravi.
Good evening, sir.
Hello, 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 Dr.
Yes, sir.
Rupinder, Dr. Ravi,
Yes,
DJ,
sir. We can
all
hear
of
you,
you.
sir. Yes, sir. Good evening.
चल,
so,
ठीक है जी, शुरू करो.
so Harsh, you can take the
रवि
lead
शंकर,
for a minute and
रवि
lead the
शंकर
call.
कहाँ पर है? रवि शंकर.
Sir,
What is Ravi Shankar doing?
sir, I am in Mumbai right now. Abhi,
Okay, which place have you joined as consultant?
sir, I have joined. I am currently, sir, working in HCG Cancer Center, Kolaba in Mumbai.
What is it?
Sir, it's a
Acha.
chain. It's basically a chain of hospitals. It's a corporate hospital, and it deals
Okay,
only with
okay.
oncology.
Mainly for oncologies, head and neck.
Only oncology, sir. Nothing else. Not head and neck. It deals with everything in oncology, right from
Okay.
radiation.
You are dealing with head and neck.
I am
ठीक
dealing
है.
with head and neck.
Good, good. चलिए. चलिए. Please start. Yes, we can start, I think.
Yes, sir.
Hello. Good evening,
Harsh,
sir.
you
Good
can
evening,
start.
ma'am.
Yeah.
Yes.
You can share your screen. Yes, Harsh, screen is
Yes.
visible. You can
Okay.
start the slideshow.
So good evening. Today I'm presenting my case of patient named Deshpal, 55-year-old male, gender by occupation, gardener by occupation in a factory, residence of Faridabad, Hindu by religion, and belong to an upper lower class as per modified Kukuswami scale in ENT OPD with chief complaint of difficulty in swelling since 4 months, changing point since 3 months, left side neck swelling since 2 months, and right side neck swelling since 1 month. History of presenting illness. The patient was apparently
Dr. Harsh, just, I would like to interrupt you here.
yes, yes, yes.
Dr. Harsh,
Yes, sir.
can you hear me?
Yes, sir. Yes, sir.
So basically, you have told about the modified Kuppuswamy scale in the presenting complaint. I think that is not required at time. Right. So this will actually come in socioeconomic history. Like it will be after you present the history. In the socioeconomic history, you will have to tell what is the literacy rate and what is the income and what is the socioeconomic Kuppuswamy scale of the patient.
Okay, sir. Okay, sir.
Am I correct, Dr. Avni and
Yes.
Dr.
Yes, sir. Yes, sir. It can be
Absolutely.
told along with personal history.
Personal history? I mean that
Yes,
should
sir.
come. I mean, in the chief complaints, you just present the chief complaints of the patient. That's all. Demographic details and the chief complaints. I mean, nothing else
Yes,
should
sir.
be told. I mean,
Okay, sir.
you can tell everything then here only in the chief complaints only. Why to go for a separate past history, socioeconomic history, and personal history? Isn't it?
Okay, sir. Yes.
I mean, it is like I mean, it is conventionally. I mean, it should not be presented like this.
Okay, sir. Should I proceed, sir?
Okay, आगे चलते हैं.
So history of presenting illness. The patient was apparently all right 4 months back when he had a complaint of difficulty in swallowing, which was insidious in onset and gradually progressive in nature. Initially, the patient has a complaint of difficulty in swelling for solids, which gradually progressed to semi-solid diet and no difficulty for the liquids. The difficulty in swelling was associated with the pain in left ear, which was insidious in onset and persistent throughout the day. The pain is sharp shooting in nature and severe in intensity, which was relieved on taking medication. The patient has a complaint of change in voice since 3 months, which was insidious in onset and muffled in nature. It was constant throughout the day with no aggregating and dribbling factors. The patient also complained of left side neck swelling since 2 months, which was insidious in onset and gradually progressive in nature. The swelling was initially of a size of a peanut, which gradually progressed to a size of a grape with no aggregating and dribbling factors. The patient also complained of a right side neck swelling since 1 month, which was insidious in onset and gradually progressive in nature. Initially, the size of a swelling was of a peanut size, which gradually progressed to a grape size. So there was history of decreased appetite. There was history of loosening of clothes present. There was no history of any difficulty in breathing. No history of halitosis and or oral bleed. There was no history of any decrease of mouth opening or loosening of teeth. There was no history of fever, night sweats, cough with or without sputum. There was no history of nasal discharge and nasal obstruction. There was no history of any nasal regurgitation of food. There was no history of decreased hearing or ear discharge. Past history, the patient was diagnosed.
May I interrupt, Dr. Harsh?
Yes, 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 sir.
Can you go on to the previous slide?
Yes, sir.
So one thing which I would like to mention over here is that you have mentioned all the negative histories, but that should be mentioned in proper order. So try to mention the local symptoms, then regional symptoms, and then distant symptoms.
Yes, sir.
Getting my point. Here you have started with appetite, then loosening of clothes, and then difficulty breathing, oral bleed, and then going to ear discharge. So there is no order in that.
Okay, sir.
Okay, Dr. Harsh, one more point. Was there any history of aspiration? This you have actually missed.
No, sir. There was no history of any
Yeah.
aspiration.
So that should be also taken in the history. That so how will you take history of aspiration?
Sir, we can ask the patient if there is any cough, if there is intake of any food
Yes,
associated with any cough. So if the ingestion is associated with any cough,
right. So whenever the patient takes any liquid or solid, there is a cough,
cough.
right? So that is also important. And regarding the history of swelling is, it's highly inadequate. I mean, history of swelling, I am not able to know. You have just told that there's a history of swelling in the right side of the neck or left side. If, can you go on to the previous slide? So what type of swelling, whether it is soft in swelling, whether it can reduce, whether it is compressible, what is the skin over the swelling, whether it is multiple, what is the site of the swelling, what is the shape of the swelling, all these things should be there in the history, isn't it?
Okay,
So
sir.
the history of swelling is, I mean, it is, it is incomplete. Were there any dilated veins over the swelling? Were there any, was the swelling soft in nature? Was it compressible? What was the exact site of the swelling? That you have to tell.
Dr. Ravi, I think
In the history, all these things will come in history. They will be confirmed on examination finding, but all these points you have to ask in history also, right? Whether there was some gurgling sound on the pressing of the swelling or not, right? Whether the swelling increased on eating or not, whether it was associated with any halitosis or not. So I think you need to work upon your history part.
There's one more thing which I like to mention is that you have mentioned left side of swelling, but left side of neck is a very broad term. You have to actually localize what left side, because say the patient is having swelling in both the sides of the neck. So it will point out whether it is originating from oropharynx or nasopharynx if we elicit our history properly. Right. Other thing is that in taking negative history, I would like to ask the patient about history of decreased smell as well, because there is possibility that this will be nasopharyngeal carcinoma coming onto oropharynx. You have taken history of some cranial nerve palsies as well, which I can see, but I think that should go in an order about all the cranial nerves.
My question is, yes, sir. Yes.
Is there any picture of the neck swelling of the patient
Yes,
also
sir, yes,
shown,
sir.
or is
Yes,
going to
sir.
show us? Can you show us that picture
Yes, yes,
of
sir.
the swelling of the neck? Do we have any picture?
Yes, sir, yes, sir. So there is a swelling.
Yes. All right. So this swelling is quite low down. that Dr. Ravi Shankar was very
So
rightly
this is,
pointing
so
out that
this
you
is a
should
swelling, sir.
tell about the roughly the exact location of the swelling in the neck.
But I can see there is some supraclavicular swelling also.
No, sir,
looks like
this is the
supraclavicular.
clavicular head, sir. This is not that the swelling.
Acha, okay. Acha.
This is the
Okay,
bony
so
component.
my question is, how does a malignant neck swelling appear
So malignant
on
neck
history?
swelling.
What history will be there in malignant neck swelling?
So on history, malignant and swelling can be present at as rapid increase in size with irregular surface and non-compressible, non-reducible, fixed on palpation if done by the patient.
Consistency.
Hard, firm to hard in inconsistency.
सबसे important consistency Ravi Shankar ने बोला ना, सबसे important
Sir, is-
consistency.
Consistency.
I think Dr. Ravi is asking in the history.
Yes, history.
History only, not examination
Yes,
finding
yes,
it.
I'm asking about history only.
It should be said that it should be a painless swelling in the region of the drainage of the lymph nodes
Perfect.
in the history.
Yes.
Yes.
Dr. Ravi, may I?
Yes, sir, please, sir.
Actually, what I feel is I need to be corrected. In history, patient cannot tell all these things. It was compressible, there were dilated veins also. At the most, patient can say, I am having a swelling in the upper part of the neck on the left side, which started as a peanut swelling and it has increased to the size of this thing.
Right. I agree.
Examination, the doctor has to do it. This is
Agreed.
my
Definitely, but many
Agreed.
of the points can be actually told by the, if you ask direct question to the
Yes.
patient, many of these
And-
points will be elicited by the history only.
Yeah,
I
and
mean,
if
if
the
you
patient is
see
intelligent enough.
the book which we used to read, S Das we used to read,
S. Das,
and
Yes.
if you go and see S. Das, there are at least 20 points in the history which are there, and we must actually ask, and it will give you some indication whether the swelling is benign or whether it's
Very right.
malignant or whether it is soft, hard. I mean, it gives you some idea about the swelling. Okay, I think we can go to the examination. Dr. Harsh?
Yes, sir.
Okay, one thing I want to ask, that you have put a lot of stress onto loss of weight and loosening of clothes.
Yes.
So
sir.
why did you choose to give it more weightage and more significance than other negative histories? Was there any thought process behind it? Maybe can you tell me about the incidence of metastasis in oropharyngeal malignancy at presentation?
So because in malignancies there is a feature of cachexia which can lead to weight loss. So I have to rule out that I have to take that history.
Agreed. Great point. So, usually in head and neck malignancy, the incidence of metastasis at presentation is less than 10%. First thing. Second thing, the primary site of metastasis is lungs. Okay, so if we are trying to rule out metastasis, we should keep these things in mind, and we should be more focused about bone metastasis or lung metastasis as the primary site of metastasis, and very specific and directed questions rather than a very generalized question.
Okay. So should I continue?
Yes, please.
Okay. So personal history: the patient is vegetarian by diet with history of BD smoking, 1 pack per day for last 35 years. So it will calculate as the 35 pack year. There was no history of any other addiction. The bowel and bladder movements were normal. There was no significant family history.
Can I interrupt?
Yes, sir. Yes.
So for BD, I do not think it has been described as pack years yet, because the pack of BD and pack of cigarette are different, and the quantification of tobacco in a BD versus cigarette is also
Yes.
different. So for BDs, as what I know, a pack has not been defined in my knowledge. I'm not really sure. I'd like
Ravi,
Yeah, right.
Ravi, generally it is 10 BDs or 20 BDs a packet.
yes, sir. 20 or 10
20,
BD. But the quantity of tobacco in a BD is much less as compared to
Also, yes, that can vary.
yes, sir. So when we say 35 pack here, it is usually standardized for cigarettes.
Cigarettes.
That to
Yeah.
the large cigarettes. If somebody is smoking a smaller one, then that also does not take into account. It is taken as 3/4
Yes.
cigarette.
Okay.
This quantification is important in prognostication, especially for oropharyngeal malignancy. We'll see how pack year has been used to decide into high, intermediate, and low grade, low risk factors. We'll see it ahead. We'll discuss about it.
Next, the general physical examination. The patient was
Okay,
conscious.
Harsh, you can continue.
Yes, sir. And the patient was conscious, cooperative, well-oriented to time, place, and person. The patient is moderately fit and moderately nourished. The vitals, vitally was normal. The PP was 126/82 mm of Hg taken in right arm supine position. The pulse rate was 82 beats per minute, taken from the radial artery. The temperature was 98.6 degree Fahrenheit. The respiratory was 66 breaths per minute. There was no pallor, icterus, cyanosis, clouding, fetal edema, or raised GBP. Continue the local examination. The first is the oral examination. On the mouth opening, there was adequate mouth opening with more than 3 finger breath. The oral dental hygiene was poor. The lips was normal. Gingival surface and gingival labial circle was normal. The tooth was tobacco stained. The buccal mucosa was hyperpigmented. The tongue on anterior two-third of the tongue was normal. The tongue movement was restricted on protrusion. The tongue was deviated towards the left side. The floor of mouth was normal. The retromolar trigone area was normal. The oropharynx on inspection on the tongue, there was a also proliferated growth with irregular surface present on the left side. The base of tongue, which was crossing the midline and extended posterior inferiorly. The soft palate was normal. The anterior tonsillar was normal. The uvula was central and normal. The tonsillar fossa was normal. And posterior pharyngeal was normal. Next, on the palpation, on the tongue, there was integrated mass present in the left, on the left, the base of tongue, which was crossing the midline, going inferior to the vallecula, which bleeds on touch. The soft palate was normal. Anterior tonsillar
Dr. Harsh, you are telling all these findings. Hello.
Yes, sir.
These findings are on direct examination of the oral cavity, or you have done an indirect laryngoscopy here?
So
the base of the tongue findings completely cannot be told on direct examination, oral
so this finding is on
cavity examination
palpation.
alone. You have not done the indirect.
Sir, I have done that also. It was coming on the next slide.
But tongue lesion was indurated. How you performed it?
So induration was on palpation.
Hello. Hello.
Yes, sir.
You have not answered Dr. Pasi's question. He said that you cannot see base of tongue without indirect laryngoscopy.
So the growth was visibly.
Sir is basically saying that the entire extent of growth, how could you see, were you seeing it directly or on indirect laryngoscopy?
So, ma'am, the full extent was seen on the indirect laryngoscopy. This is the only the palpation part.
You are telling us the examination tongue depressor.
Yes, sir. Yes, sir.
So you should specify that on that this was yes on using tongue depressor.
Tongue depressor.
Okay, proceed now.
Okay. On indirect indirect laryngoscopic examination. On the base of tongue, there is also prolific growth present involving the base of tongue extended inferior to the bilateral bilicula and the lingual surface of the epiglottis. The bilateral ariepiglottic fold was normal.
Dr. Harsh,
yes, sir.
The diagram which you have made actually shows growth in the vallicula, not in the base tongue, right? So the base tongue is totally free. I mean, what I can see from the diagram, the growth which you have shown is actually involving the vallicula, not the base tongue. So this should actually, I mean,
yes, sir, towards the base.
The curved part which actually denotes the base tongue, that should have been involved, right? In the diagram you have shown the base tongue totally free.
Yes, sir.
So I think you need to, I think you don't, I mean, you don't have the idea of what is base tongue and what is vallicula. So can you tell me the parts of oropharynx?
Yes, so
What are the parts of oropharynx?
The part of oropharynx is certain tonsils, the soft palate, base tongue.
Base tongue, tonsil,
soft palate, and the posterior pharyngeal wall extended from the soft palate to the hyoid wall. Posterior pharyngeal wall extended.
Posterior pharyngeal wall, very good.
Extended from the soft palate to the hyoid wall.
No, not soft palate, from the hard palate.
Hard
palate.
Line drawn through the plane of the hard palate.
Hard palate.
Soft palate तो move करता रहता है ना. We need a fixed point. So and the oropharynx also includes the anterior and posterior pillar of tonsil. The soft palate, the base tongue, the posterior pharyngeal wall, line drawn from the hard palate, and the lower line is through the hyoid bone. Okay, and it also includes the tip of the epiglottis and the laryngeal surface of the the pharyngeal surface of the epiglottis.
Yes.
And the vallicula. So am I clear?
Yes,
the tip of the epiglottis, the pharyngeal surface of the epiglottis, the vallicula, and the base tongue, these are all parts of oropharynx.
And how do you demarcate base of tongue? Which part of the tongue do you say as base tongue?
Right.
So the base tongues are entirely the circumvallate, the part posterior to the circumvallate of papilla is the starting point and goes towards the vallicula, till the vallicula.
So
is the base tongue.
That is definitely very good on examination. And on radiology, how will you ascertain what is base of tongue? So we'll discuss when the radiology part comes. I think let us proceed.
The bilateral arachnoids was normal. The bilateral piriform sinus was normal. The bilateral falls and the the vocal cords appears normal. The bilateral vocal cord is mobile, and the glottic chink was adequate, appears adequate. Next is the neck examination. On inspection, there is single ovoid swelling of size 2 into 2 centimeter present in the left level 1.
Just wait, Dr. Harsh.
Yes, sir.
Did you examine the tonsillolingual sulcus? Because
yes,
you have not commented on tonsillolingual sulcus.
Yes, sir. So it was involved.
So how did you examine the tonsillolingual sulcus?
वही तो नहीं हो रहा ना.
Yes. So the tonsillolingual sulcus was involved.
How did you examine the tonsillolingual sulcus?
Around palpation.
Hello, Dr. Harsh.
Yes, sir.
My question is, how did you examine the tonsillolingual sulcus?
Sir, on palpation.
On palpation?
Yes, sir.
So it was on palpation, it was indurated?
Yes, sir. It was indurated. Yes, sir.
तेरी आ रही है, इसमें से तेरे स्पीकर में से आ रही है.
Dr. Ishwar Singh, sir, आपका mic, please. Can you switch off your mic, please, sir? So tonsillolingual sulcus is a difficult to examine area, right? So what you need to do is to use the tongue depressor. That you should use 2 tongue depressor basically to examine the tonsillolingual sulcus, right? And it is important because if the tonsillolingual sulcus is involved, then if you want to take the patient for surgery, you need to remove the part of tonsil as well as the base tongue. Okay, so Dr. Harsh, you can proceed.
Yes. On the neck examination, a single ovoid swelling of size 2 into 2 centimeter present in the left level 1B with well-defined margins with overland skin normal, and there was no dilated veins. A second swelling was seen on the right side with a single ovoid swelling of size 2 into 2 centimeter, which was present on the right level 1B with well-defined margins with overland skin was normal, and there was no dilated veins. There was no other swelling seen. The external laryngeal framework and the contour appears normal, and the trachea was central. On palpation, on the left side of the neck, there was no local rise temperature, no tenderness, and the inspection findings were confirmed. It was firm to hard in consistency with smooth surface. Margins was well palpable and fixed to underlying structures. The skin over the swelling was pinchable. On the right side, there was no local raised temperature, no tenderness. Inspection findings were confirmed, which is for firm to hard in consistency, smooth surface. Margins was well palpable and fixed to underlying structures. The skin over the swelling was pinchable. There was no other swelling palpable in the neck. The laryngeal framework was normal. The laryngeal capitus was present, and the carotid pulses was palpable. Next is the nose.
Dr. Harsh, 1 second.
Yes.
So, what was the size of the node?
So 2 into 2 centimeter.
And it is fixed to underlying structures.
Yes, sir. Yes, sir.
In which plane? In vertical plane or horizontal plane?
Sir, in the horizontal plane.
It is fixed to. I really doubt that it will be fixed to underlying structures in horizontal plane as well. Because 2 into 2 centimeters is a really very small node.
Sir. But, sir, but it was fixed. I tried to move the swelling, but it was not.
Okay.
Recorded that.
Okay. Please proceed.
So again, upon palpation, you must mention the size of the lymph node, because on inspection you can just give an approximate idea, but on palpation you can actually measure it. So the measurement should be told in the palpation.
Okay, sir.
Right? That is important. And you should also talk in levels of lymph node. Level 1, 2, 3. I mean, that is how you should actually tell in the palpation. Level 2 lymph node, enlarged, 2 into 2 centimeter, fixed to underlying structure. So that is how you should present.
And the other thing is, when you are mentioning fixed to underlying structure, do mention the planes in
Which plane?
So if it is fixed in a vertical plane as well, it means that it is high probability that it is fixed to the great vessels as well.
Yes.
So this is something which we have to keep in mind.
Okay. Should I continue? So next slide.
Yes.
Next is
Continue,
the nose examination. On inspection, the external framework was normal. The ala, the column and the vestibule was normal. On anterior rhinoscopy, the septum, there is right side DNS. The nasal mucosa appears normal, and the infradermal was also normal. The ear was also within normal limit. Systemic examination.
Can you go back, Dr. Harsh? What about posterior rhinoscopy or nasal endoscopy?
Posterior endoscopy.
Or nasal endoscopy?
Examination.
I missed that.
That is an important thing to do,
Yes,
because since the patient is having bilateral nodal metastasis, we should always keep in mind the possibility of nasopharyngeal malignancy. Anyways.
Okay.
Systemic examination of the chest, there is bilateral air entry present. There was no added sounds. And see this the vascular system, the cardiovascular, the S1 was present with no murmur heard. Abdomen, there was soft, non-tender, and there is no organomegaly. The organ cranial nerves was functional. So my provisional diagnosis is the growth in the oropharynx, subsides the base of tongue. The most probably is malignant with bilateral cervical lymphadenopathy. With the clinical TNM symptoms is E4A, N2C, and MX.
Why N2C?
Because
So
there is
diagnosis should include side, which side, right side or left side?
so yes sir, left side.
Left side of base
Left
tongue.
side base tongue, yes sir.
Mhm.
And sir, N2C is because there is bilateral lymph node. That's why sir, N2C.
And what will be N3B?
N3B,
You
sir,
said
if there
it
is,
was fixed.
yes sir.
Sorry, Ravi. Yes, you were telling something.
Exactly same question. So what will be N3B?
N3B
When
is
you
if there is
say a node,
extra capsular spread is present.
so how will you ascertain extra? So clinical N3B is when there is clinical evidence of extranodal extension. So how do you ascertain the clinical, what is the clinical evidence of extranodal extension over here?
So if there is fixity of the nodes
So
to the underlying structure.
I hope you get what extranodal
Yes, sir.
extension means.
Yes, sir.
Extranodal extension means when the disease has spread beyond the capsule of the node, gone into the surrounding area, and because of that, the node has become fixed to that structure.
Yes, sir.
Sir.
So which class staging system did you use?
Ma'am, I have used the AGCC classification, the AGCC 8th edition classification.
AGCC का जो लेटेस्ट 8th एडिशन है ना, उसमें एक्स्ट्रा
Yes,
नोडल
sir.
एक्सटेंशन ऐड हो गया है.
Yes, sir. Yes,
वही
sir.
पूछना जा रहा है आपसे.
Yes, sir. And
One more thing. Do we have sufficient data at this stage to stage the disease? Are we missing something? Is there some workup required before we go for staging at this juncture?
yes, sir. Yes, sir. The HPV staging, the HPV
Excellent.
workup should be done.
So as per 8th AGCC staging,
Yes.
HPV staging is something which is mandatory to stage oropharyngeal malignancy. Though in our setup, many institutes are not actually doing HPV staging. Can you state why?
So because of the high cost of the human papilloma.
The cost is not really very high. So we can use surrogate marker, we can use P16.
P16.
It's not really
because
very.
of the not much incident in the Indian population or the Asian population of the HPV.
So that brings to me next question. What is the incidence of HPV positivity in oropharyngeal malignancy in Indian population?
Sorry, sir, I'm not aware about that.
Any rough figure? Can you come to any rough figure?
It's low.
20 to 30%.
Excellent. So 30% is a bit high on the higher side. It ranges somewhere around 20%. To be very specific, some studies have shown up to 22% max and minimum up to 12 to 15%. So you can give a rough figure of around 15 to 20%. So that incidence is really low. And to look at it, there is a multiple clinical parameters which point towards the possibility of which being a HPV positive disease. Can you quote the clinical features of a HPV positive patient?
Yes, sir. So starting from the demographic profile, the patient mainly is seen in the Caucasian population. With
We do not have Caucasian population. We are talking about Indian population,
Indian
right?
population only, sir. If there is any history of any repeated sexual contact history,
Okay.
and if there is on clinical examination, there are bulky nodes, bulky cystic nodes can be seen.
Excellent.
And with
primary and bulky cystic nodes.
Yes, sir. Small primary and bulky lymph nodes can be seen in
Young patient.
Younger
young
patient.
patient.
No history of addictions.
Addiction.
No history
yes,
of tobacco use or any addiction. Please continue, madam.
No, Dr. Ravi.
So, younger patient, no history of any addiction, small primary, large nodes, cystic nodes. Apart from that, the patient will, of course, give a history of promiscuous sexual behavior. So that is what you have to elicit, not a history of any sexual contact. So one history of one single sexual contact does not point it towards the HPV positive patient. Okay. And history of any oral sex history is very important. Okay. So these are some of the features which point to a possibility of HPV malignancy. Okay. Please proceed. Do you know about...
To add one thing, like the HPV has not much role in Indian population because of the low incidence. Plus, even if you know whether it is HPV positive or it is negative, the management does not change. Whether it is a HPV positive or it is an HPV negative, the overall management of the patient does not change. Though the prognosis will be different because HPV positive patients have a better prognosis than... Yes, sir.
Prognosis depends on HIV has a prognostic value.
Wait, that is HPV. If it is positive, then the prognosis is better. That is.
And
does those tumors respond better to radiation as compared to HPV negative?
Right. Yes.
So what is the reason why HPV positive tumors have got a better prognosis as compared to HPV negative tumors? The radiation does not see whether you are HPV positive or negative. Then why is there a difference?
Because this HPV related carcinomas respond to chemotherapy better.
Why? So there is a very specific some genetic mutation which is present in smokers, which is not there in non-smokers. Some guardian of genome.
You have given the answer.
So usually smoking has got a propensity of, or it causes P53 mutation. While how does HPV mutated or HPV affected cells work is that they lead to a down regulation of retinoblastoma and P53 gene. So if infection part is taken care of, usually since there is no mutation, the overall outcome improves. Getting the point? Please proceed.
So this is the FOL, the fibrotic laryngoscopy which was done in this patient. So is this video is visible of this buffering? So as can we see, there is the growth present in the left side base of tongue, and the larynx part appears to be normal in the fiber optic laryngoscopy. This is the CCT's neck images of the patient, showing the growth in the oropharynx, and the laryngeal structures can be seen, which is normal. This is the CCT neck report, which is showing the enhancing ulcer-proliferative growth of size measuring to 3.2 into 6.1 into 5.8 centimeter, involving the base of tongue and the crossing the midline, and the lesion is
Harsh, what is a better modality of investigation over here for this patient for imaging?
It's a base of tongue.
So we can go for CE MRI of neck.
And why CE MRI over CCT? What advantage does it have?
So it can the CE MRI can show the soft tissue involvement more better than the CT scan, and involvement of the...
What exactly in soft tissue do you want to see?
So depth of involvement in the base of tongue and
How is depth going to affect our management?
that involvement of any so not in the management, but if there's involvement of the muscles, it can upstage the
Actually,
disease.
it can play a role in management as well, especially for early tumors, right? Wherein you can provide the patient with a option of surgery over some other radiation or non-surgical treatment line. So therein, MRI plays a very important role, and even in advanced cases, MRI has a role in telling us about the involvement of any neurovascular structure or involvement of any parapharyngeal or retropharyngeal space, the presence of disease over there, which will have an implication in further management of the patient. When will you consider doing a PET scan for this patient? Or in a case of oropharyngeal malignancy?
Sir, in pre-op, we can advise PET scan to rule out any distant metastasis.
So when you are suspecting distant metastasis, right?
Yes, sir.
Other
and in the
scenarios?
Sir, in the post-op for the follow-up of the patient, PET scan can be advised.
No. We are talking about naive patient right now. In we'll discuss about the post-op patient, post-treatment patient as well. In treatment naive patient. So multiple neck nodes is one indication. Large neck nodes in the lower level, level 4, level 5 neck nodes. These are the cases which have got a higher chances of distant metastasis being present. Okay. So these are the cases where you can consider doing a PET scan for the patient.
What is the commonest site of distant metastasis?
The lungs in oropharyngeal carcinoma.
What is the incidence of lung metastasis?
So 10 to 15%.
So I think one of the important indication for PET is to rule out second primary.
Second primary.
So that is also one of the indications for PET.
Second primary, and also in a case of recurrence. So if a treated case comes to you with some nodal metastasis, then also you will consider doing a PET scan. And coming on to that value, it's not 10 to 15%. 10 to 15% is actually very less. It's up to upwards of 60%. Okay. So all the head and neck cases which present with metastasis, the incidence of metastasis to lung is upwards of 60%. Okay. So that is why in many cases, due to logistic reason, even if you do a good NCCT thorax, it is considered sufficient because the chances of metastasis to other sites are less. And coming from
in the lungs, because it is the first filter where the venous return comes and gets oxygenated, so the malignant cells get trapped there. So that is the first site. So that's why the lung involvement is the first and it is maximum.
And among all the sites of head and neck, which site has got maximum propensity for distant metastasis? So it's nasopharynx. Nasopharynx has got almost 10 to 11% chances of metastasis at presentation. So PET scan becomes kind of a primary modality of investigation for nasopharynx because of the incidence of metastasis. So when we
Ravi, bolo.
Sir, I was asking ki we have not done biopsy of the patient yet.
Yes.
When would you consider doing biopsy of the patient?
Sir, after we have done the imaging, we'll prepare the patient for the biopsy.
So any specific reason that you want to do biopsy after imaging in such a large lesion?
Sir, because
it is T4N3B.
Yes, sir.
Even if you upstage the disease, what is it going to be? It is going to be the same lesion.
Same, yes.
Okay, and what is the incidence of upstaging of the disease? Well, by what % does the disease get upstaged? Even if it gets upstaged, it does not get upstaged by more than 10 to 12, 20%. Okay. Any other reason why I will still consider doing MRI? So it's a plus minus thing. What we usually do in practice is that patient comes to us. If biopsy is possible, we take the biopsy using some fiber optic or some flexible endoscopy, right?
Yes, sir.
But imaging is still advisable. Can you give me some other reason why imaging should be preferred over a biopsy? Something related to examination under anesthesia or DL scopy?
Sir, if we get image first, we can have a high chances to get the biopsy from that side in the if the patient is under GA.
Perfect. So first thing, it will help us in directing our biopsies. Perfect. Second thing is, it will give us an idea of the airway. So if you're planning to take the patient up for some general anesthesia procedure or some other procedure, when we are expecting some kind of bleeding, it is better that we are prepared with an idea of the airway in our mind, and if required, we should be prepared with tracheostomy as well. Okay.
Yes, sir.
Please proceed.
So the biopsy was done in this patient. So it was concluded as the moderately differentiated squamous cell carcinoma.
So
to review your diagnosis, you said unilateral. CT showed bilateral invasion of the base of tongue.
So because the lesion has crossed the midline, it was starting on the left side and you cross the midline of the base of tongue.
in this biopsy, as we have already discussed, would you like to send this biopsy from any additional investigation?
Yes, sir. Yes, sir. I will like to send the biopsy for the immunohistochemistry for the P60 to rule
So
out any HPV.
what is the gold standard test for HPV?
So HPV gold standard is the
HPV DNA.
in situ hybridization or the DNA or the PCR polymerase, PCR or the HPV DNA.
It is
In situ
mRNA, RNA-ish. In situ hybridization for mRNA. Okay. Why mRNA is the gold standard? Any idea? So I'll just tell this for the benefit of the audience, that when EBV infects the cell, HPV infects the cell, the HPV DNA can be present in a dormant stage. Only when it is undergoing multiplication, then only mRNA will be formed. So when we are actually looking for mRNA, and if mRNA is present, then it gives a sure shot picture that, okay, this cell is actually actively infected and this by HPV, and this cancer is because of HPV. So there may be times when HPV infection can be present, but the cancer would not be because of HPV. That is the same scenario when the HPV virus is dormant. Getting the point? Hence, mRNA-ish, RNA-ish is the gold standard test. Okay. Please move ahead.
So which HPV is actually, which strain of HPV is responsible for oropharyngeal cancers?
So most common is HPV 16. Although other variant of HPV 18, 31, 33 can also be seen in HPV.
Right.
Squamous cell carcinoma.
Okay, so you have the biopsy now and you have the radiology. So in the radiology CT scan, I mean, I was reading the report. It was written that it is involving the uvula. I don't know why it is involving uvula. Can you go back to the CT scan report?
Yes, sir. Yes.
So here the lesion is seen to involve involving uvula, hyoepiglottic ligament, and upper surface of epiglottis. I don't know why they have written uvula. I mean, probably it's a mistake.
Yes.
So you have the reports and you have the staging system now of the tumor. So how you are going to manage?
I will advise as the lesion is locally advanced. So I will advise the patient for chemo and the radiotherapy.
Okay. Why not surgery?
surgery, sir, because it, surgery it won't be possible to get a clear margins in this patient, and we'll going towards organ preservation to retain the swallowing and the speech part of the patient. That's why we're going for the chemo and the radiotherapy.
What are the contraindications for surgery in oropharyngeal malignancy?
So the indication, if there is involvement of the skull base, in involvement of the large vessels or the carotid vessels,
Any other?
If poor performance of the patient, if the patient is not GF, general anesthesia fit with.
So before we move on to that, let me ask you, what are the surgical modalities of treatment available for oropharyngeal cancer patients in general? Let us not discuss about this case. In general, about oropharyngeal cancer patients, what are the surgical treatment modalities available?
For the early cases,
All early advanced, you can go in a graded manner.
Okay, so starting from the transoral surgeries, the transoral laser microsurgeries, the transoral robotic surgeries, and then there is the open approaches like the lip split mandibulotomy, and there is.
Is there any other transferal mechanism or surgery?
Sorry, sir.
Any other mechanism of transferal surgery?
Yes, sir. Transoral ultrasonic surgeries.
Right.
Ultrasonic surgeries. And TOS, TOUSs.
Great.
And
so this kind of lesion, this is kind of a lesion in the midline and going bilaterally. Suppose this lesion was localized to one side of base of tongue and going on to say partially on tonsil. Will you consider this patient for surgery in that scenario over chemoradiation?
Sir, involving the base and tongue and the tonsil, both.
Suppose this lesion was involving base of tongue and tonsil on left side. There was no disease on midline and the lesion was around 1.5 centimeter away from midline. What would be your modality of treatment? You said
tonsillingual sulcus.
For the open approach,
you'll go for open approach and not CTI.
We like to firstly stage the disease about the extension.
You tell me what would be the stage of disease? Exactly same disease with lesion on left side base of tongue going on to tonsillolingual sulcus and tonsil.
We'll go for with this patient, then we will
you
go
are
for
you are right.
CTRT.
Don't be scared. You are right. Let us just think about it. You are saying CTRT. Why not surgery? So we have evidence. So there was one systematic review and meta-analysis conducted by Parsons et al. It very well showed that the overall complication rate and mortality after surgery. So initially surgery was being done. Okay. The complication rate, the rise tube dependency and tracheostomy tube dependency was much higher in a surgical case as compared to CTRT case. So initially patients used to go for both surgery as well as chemoradiation. There was no standardized practice. So based on that data, eventually it was decided to, okay, surgery has got higher complication rate and higher morbidity. Hence, and the outcome was similar of both surgery as well as chemoradiation. So this is a lymphoid rich area. Hence, it is more sensitive to chemoradiation.
What was the name of that surgery which used to be done? It has that some funny name.
So it was, they used to do, most of the cases they used to do by lateral pharyngotomy or open approach. I do not think that they had mentioned any specific name over there.
Commando. Mandible. Base of tongue, tonsillolingual sulcus, tonsil. Lateral pharyngeal wall and base of tongue that.
But I think you can do TORS if the lesion is not crossing the midline.
So for very small lesions, which are well localized and well lateralized, wherein you are sure that you are not going to damage more than one lingual artery, those are the cases which you take up for surgeries. And that specifically for oral surgeries. Even if you do mandibulotomy and approach the disease, that also has got a higher morbidity as compared to chemoradiation. Plus, the other thing is that even if you do surgery, you will need to address the patient's neck. And the chances of extraneural extension being present in an N0 neck is upwards of 30%. So there's 30% possibility that a patient with N0 neck is going to land up with a triple modality treatment. So in order to reduce that and minimize the number of modalities, it is better that for early stage tumors, which we know, for early stage tumors, which is going to damage both the lingual arteries, we send them for upfront for single modality radiation therapy. Sir, Ravi sir.
Yes.
Ma'am.
You have discussed good points.
So if you can I just ask something, sir? So if you're
yes, Dr. Avni, please.
If you're doing TORS, will you do neck dissection first, or would you be doing the primary first? What will you address first between the two?
Neck dissection will be addressed first, then we'll go for the TORS.
Why is that?
Because we'll ligate the vessels and we'll get a bloodless field if we're doing the TORS, and then we'll proceed.
But lingual artery is ligated in the neck.
You know, lesser strangle.
We'll go.
How many cases have you seen which have gone for TORS actually, or some transoral surgery?
The trans robotic, I've seen the trans robotic surgery or trans.
How many cases usually go for transoral surgeries of oropharyngeal malignancy?
T1 and T2 stage tumor.
How many cases have you seen going for transoral surgeries? So the incidence is really very low. Can you point out to any factor why this incidence is so low in India?
Because the presentation of the patient is late when the disease has
not
spread.
exactly late. Which is the most common site of oropharynx which gets affected in Indian population versus the Western population?
So base of tongue in oropharynx.
And what in Western population?
Tonsil.
Perfect, very good.
Tonsil.
So in Western population, it is tonsil and it is associated with HPV. In Indian population, it is mostly base of tongue. And base of tongue disease, they tend to infiltrate early as compared to a tonsillar lesion, which is a well-demarcated structure. Hence, the chances of a
I think Ravi sir's connection is.
Hello.
Hello.
Yes.
Sorry, my phone got disconnected. Sorry. Continue.
So anything else to be discussed?
I would like to ask, when would you call a lymph clinically? When would you call a lymph node significant?
If the size is more than
Clinically, based on your examination.
more than 0.5 to 1 centimeter neck.
Be specific.
0.5 centimeter. 1 centimeter, more than 1 centimeter.
All nodes?
More than pea size.
Recording in progress.
What about juglodigastric nodes?
Digastric one, I think 0.5 centimeters. That one.
Sorry?
0.5 centimeter is, if more than 0.5 centimeter is digastric.
No.
And more than 1 centimeter.
So for juglodigastric, it is more than 1.5 centimeter. All other nodes, it can be more than 1 centimeter. But juglodigastric, it's more than 1.5 centimeter.
Dr. Harsh,
Yes, sir.
you said there is a apple size swelling in the neck, right?
No, sir, grape size.
Grape size.
Yes,
Oh,
sir.
okay. But your CT scan report shows it's sub-centimeter. Then what is the size of your grapes?
So clinically, it was 2 into 2 centimeter was palpable.
But on CT scan, I think it is sub-centimeter to centimetric lymph nodes.
Yes, sir.
I think there is no correlation in between two.
So, sir, at the time of presentation, as is seen in this image, in this image, the nodes was clinically seen in this picture. It was 2 into 2 centimeter only. So you're not audible, sir. Your mic.
Was there any gap between the examination and CT scan?
Yes, sir. Yes. Sir, it almost, sir, 20 to 25 days.
Okay. So, Dr. Raman,
yes, sir. We can take the final comments from the examiner.
we can take any questions.
Yes.
Any questions in the chat box if there?
What is the final outcome? What should be the treatment of choice for this patient?
The chemotherapy and the radiotherapy is the preferred treatment for this patient.
So what chemotherapy will you give to the patient, if I may ask?
Yes, sir. So platinum-based chemotherapy can be given cisplatin.
And before radiotherapy, during radiotherapy, or after radiotherapy? So when you answer, you say that the line of treatment, in your opinion, will be concurrent chemoradiotherapy. Okay, concurrent when you are giving chemotherapy along with radiotherapy.
Is there any role of immunotherapy?
Yes, ma'am. There is a role of immunotherapy can be given against the when there is a drug. I just forget that name is being used in this cancer patients. I think pembrolizumab is used.
So it's pembrolizumab.
Pembrolizumab is used.
So what is basically immunotherapy?
Will act against the epidermoid growth factors, which will cause the carcinoma.
What?
So
I've not read that section. I've just read that drug only.
So, Dr. Harsh, this patient has come to you. You have done full examination, history taking, imaging, biopsy, sent it for ISC as well, and advise the patient to go to CTRT. Okay, concurrent CTRT. Now this patient asks you, Doctor साहब मैं बच तो जाऊंगा ना, क्या chances है कि मैं बचूं? So what is going to be your answer to the patient?
Sir, in HPV negative patients, the prognosis is guarded with approximately is 40 to 50% the prognosis factor. And
For all stages? Or you're specifically mentioning for this patient?
for this patient in locally advanced tumor.
For grade 1?
For locally advanced tumor, grade 3 and grade
Locally
4.
advanced.
In HPV positive patient, the prognosis is a little better, with good prognosis of approximately 80 to 90, 70 to 80%.
Okay.
So, Dr. Harsh, what are the high risk factors for poor prognosis in oral cancer, oropharyngeal cancers? What are the high risk factors?
So high risk factors can be if there is addiction of smoking and alcohol, smoking and alcohol
Yes.
with and these are the major risk factors with if there is any occupational exposure of the organic solvents or pesticide, if there is.
Right.
You are
If
missing
there's
the most important factor, Dr. Harsh.
Uh,
HPV.
HPV,
HPV.
if there is history of sexual contact.
So HPV
Oral-
positivity or HPV negativity is the most important factor. It is so important that it has been used to give a new staging. We have to understand that. So you cannot miss HPV when someone asks you the prognostic factor. Second most important prognostic factor is smoking. So Kian Ang in their paper, they have divided, actually they did a recursive partitioning analysis of almost, I think, some 370 patients, something of that sort. So what they saw that patient with HPV negative and a history of pack years of more than 10 pack years had the worst prognosis. Then HPV positive and more than 10 pack year was intermediate prognosis. Then HPV positive and less than 10 pack years was the low risk, was the lowest risk.
Lowest.
So these are the two most important prognostic factors.
Right. Very well.
I think smoking with alcohol is more dangerous as compared to smoking only.
Yes, sir, it is.
Benzopyramines and aldehyde and other aromatic amines are dissolved in the alcohol. They are carcinogenic, I think so.
Right, sir.
Yes, sir, absolutely.
I mean, are there any more questions?
There is a question in the
Generally,
chat.
oropharyngeal malignancies are difficult to manage. Basically, they are. They are. Their prognosis is also poor, and treatment actually causes a lot of morbidity. There's a swallowing problem, and if you see the radiotherapy and chemotherapy side effects also, right? So, and as far as exam is concerned, you might get a short note or maybe a short note on TORS or utility of TAUs in oropharyngeal cancers. You might get a short case also sometimes, right? Generally, oral cavity cancers are more common in India, and they are usually kept as a long case in exams, right?
And
or
HPV, a role of HPV in oropharyngeal
yes,
malignancy.
and another very important question is like role of HPV in oropharyngeal cancers. What is the role and what is the prognosis and what are the risk factors, right? So that is as far as your MS exams is concerned. Anything else, Dr. Ravi Shankar and Dr. Avni, to be added?
Sir, one thing I would just like to mention that is not going to be a part of the curriculum, but
Yes.
I think a little bit knowledge or information about the current ongoing debate about de-escalation of treatment for HPV that won't hurt, and at least that will give students an idea that why HPV infection is so important. Discussion about HPV
Right.
infection is so important. So de-escalation is something which you should go and browse, at least read. And actually, Scott Brown chapter on oropharynx is very well written. It's wonderful
Yes,
chapter,
yes.
and it does discuss about de-escalation.
Right. So actually, the new Scott Brown 8th edition is really beautifully, written. It is far much better than the 7th edition. And
Yes,
I will
sir.
advise all the students to actually go through the 8th edition. It's beautifully given, and they actually have given evidence also for all the statements which they make in the text. So I will advise all the postgraduate students to please go through the Scott Brown. And the chapter on hypopharyngeal malignancies is actually written by Dr. Prathamesh Pai from Tata Memorial, right? Dr.
Yes.
Prathamesh and Dr.
Deepa Nair.
Deepa and one more, Dr. Prabhash, right? So I think that's a great achievement as far as Indian
Actually,
Indian cancer surgeons are concerned, right? So you must read about that chapter. Hypopharyngeal malignancy is also, it is also difficult to diagnose and it is difficult to manage. Hypopharyngeal malignancy has also, they are poor, they have poor prognosis. So both the chapters in Scott Brown.
Right, sir. So we don't have any more comments or questions in the chat box also. Good evening, Ishwar sir. Sir, any final words or any comments?
Comment is that one should read thoroughly and examine the patient, see both the cases, and what Ravi said, I look into it.
And
Raman,
Raman, I would just like to add one thing, that Ravi Shankar has actually given good important points, learning points, and very, very important points
from
given by
exam
Ravi
point of
Shankar.
view,
So
and he has
thanks,
clarified